Hello, my name is Dr. George Freeman. I am a cardiac anesthesiologist at St. Joseph's Heart Institute in Tampa, Florida. I did my undergraduate studies at State University of New York in Stony Brook, New York. After that, I went to medical school at the University of Miami in Florida, and that was followed by my anesthesia residency and training at the Georgetown University Hospital in Washington, D.C. So to become a cardiac anesthesiologist usually requires a year or two of extra training after you've finished your anesthesia residency. You become versed in managing patients in the cardiac operating room, in the intensive care unit, and special monitoring procedures that are required for cardiac surgery. So the benefit of this TAVR procedure is that it's much less invasive than a traditional aortic valve. In a traditional aortic valve, the patient has what we call a sternotomy, which is the front of their chest is opened up, the rib cage is opened up. We typically have what we call a heart-lung machine, where the patient's heart is put on a heart-lung machine. Their circulation is put through a circulatory pump, and it's very invasive and a very difficult operation for the patient to get through. This procedure is a lot less stressful on the patient. It requires much less blood transfusions. The patient is able to be extubated, which means we get the breathing tube out in the operating room. They go to the recovery area breathing on their own, and they're awake very soon after. In the traditional procedure, the patient is on a ventilator for many hours to days after the procedure. So the procedure really makes it a lot easier for the patient to recover, and it's a lot more elegant procedure than the classic aortic valve. Multidisciplinary team is kind of a requirement of this type of procedure because it requires very close coordination between the cardiologists, the surgeons, and the anesthesiologists. Everybody has to be focused at the task at hand, and at the appropriate moments, everybody is doing their part and coordinating so that this valve can be deployed as it should be. Well, prior to surgery, we take a good look at the patient's history and make sure they're in optimal condition and find out about any comorbidities they may have prior to surgery so that we know what we're dealing with. We have a lot of things to do after getting the patient to the operating room, going to sleep, putting a breathing tube in. We put central lines in, which are invasive monitors that go from the patient's neck or shoulder veins up through the heart, monitor their heart functions. We put blood pressure monitoring lines in, and we'll also put what we call a transesophageal echocardiogram probe that sits in the patient's esophagus and takes real-time ultrasound pictures of the patient's heart during the procedure. And this enables us to really see exactly where things are positioned and what the patient's anatomy is so we can deploy the valve effectively.